All right, hey, what's going on, guys? Welcome back to another video. I know it's been, again, a little while since I posted something, but have a day off here. I wanted to go ahead and put something together. So this is going to be a quick one, and basically all I'm going to talk about is the insulin bridge in DKA. So with that being said, let's go ahead and get into it. And I guess I'll preface this first. DKA stands for diabetic ketoacidosis. If you want, I can make another video getting into some of the specifics about that, but for the purposes of this video, I'm only going to be discussing the insulin bridge. All right, so one of the first things you need to understand with DKA is that these patients generally are going to go up to the ICU or the intensive care unit. And the reason they go up to the ICU is because they need to be started on an insulin drip, because insulin is going to be the definitive treatment to resolve their DKA. And they also need Q&hour glucose checks because you need to be monitoring the glucose frequently to make sure that the treatment is progressing properly. So first question with the insulin bridge, first you have to resolve the DKA. So the question is, how do you know when that DKA has resolved? So all of these can be evaluated essentially with lab values. And it kind of depends who your attending is on your institution, what some of the guidelines are, but this is just kind of a broad definition of what you can kind of look for to know if your DKA has resolved, okay? Now let's go ahead and get into it. So first and foremost, you're gonna want a glucose that is below 200 to 250, all right? And that's just kind of the broader range I found when I was looking at resources online. Also, you want to have your bicarb, it should be greater than or equal to 15. Next is going to be your venous blood gas or pH greater than 7.3. And then finally, most importantly, you want to make sure your anion gap is closed. So less than or equal to 12. I think this is a good place to start. I wouldn't say these are the hard and fast rules that everyone agrees upon for when your DKA has resolved. But I've seen some attendings really look at like the anion gap, the glucose, and the bicarb, not so much the VBG, but I would just keep all of these in the back of your mind to think about, but know that it could change based on your institution. Second, let's just talk about what the purpose is of the insulin bridge. So again, your patient comes up to the ICU, they're on an insulin drip, right? Once their DKA resolved, you want to try to transition them to subcutaneous insulin, but there's a step in between. And that step in between is, again, it's going to be the insulin bridge, which takes about 1 to 2 hours. But essentially the purpose of this is you want to ensure that the patient is getting adequate insulin before you discontinue the drip and transition them to sub-Q insulin. It's possible that you could have a patient who has their DKA has resolved, but if it's not treated properly, they can get DKA again while they're in the hospital. So the whole purpose of this is just to make sure they have the proper amount of insulin on the drip and you're transitioning them to the subcutaneous without taking that big leap of just stopping the drip abruptly and going right ahead to sub-Q. The next question is, okay, so how exactly do I look at dosing these patients for subcutaneous insulin? Now there's two categories that patients fall in. So you've got patients who are known diabetics and they know what their home dose is versus naive. So these are patients that have not been on insulin before. The home dose is pretty straightforward. All you do is continue them on what they were on before. Very simple. Now, the second group is going to be a little more difficult, but for this, it's still not too bad. So what you need to do is you're going to dose them based on their weight, and that's going to be 0.5 to 0.8 units per kilogram. So once you calculate the total units, you then take that amount total. So say we have a 70 kilogram patient. All right, you're going to take that total amount and you're going to split it into a long-acting dose, aka basal dose, and a short-acting dose that the patient will take 3 times a day before each meal. And then with that long-acting, that's going to be your glargine. With the short-acting, with meals, that's going to be like your Lispro. So essentially, if you were actually calculating this on a 70 kilogram adult, you do 35 here, 35 here. And for the long acting, you're basically set, but for the 35 here, you would split this into essentially breakfast, lunch, and dinner. All right, and that's how you go ahead and dose that. All right, guys, well, that's all I have in this video today. I hope that was helpful. Let me know if you have any questions, comments, concerns, or any other thoughts on this. Always open to feedback. And again, if you have any other topics you want me to discuss, please leave a comment, let me know. Thanks, guys. I'll see you next time.